Hello, good evening everyone, and a warm welcome back to the EUROGEN webinar series after the summer break. Thank you very much for joining us. Just before we get started, I'd like to take a couple of minutes to explain a little bit about what EUROGEN is and does. EUROGEN is one of the 24 European reference networks created by the European Commission in 2017. And our ERN, EUROGEN, covers rare urorectogenital diseases and complex conditions that all require highly specialised surgery. And we are a network of 56 specialist healthcare providers in 20 member states. And our aim is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urorectogenital diseases and complex conditions. So they're all conditions where the expertise is really rare. So some of our activities, well, we conduct virtual consultations using a secure IT platform provided by the European Commission to the ERNs, which is called the Clinical Patient Management System. And you may have seen that on the slides at the very beginning. And we can do this cross-border and free of charge. Our network of experts is able to provide advice to any clinician based in the European Union that may need advice on a tricky case. So I would really encourage any of you out there, please do feel free to get in touch. We'd be delighted to help. We also carry out training and education activities. We write clinical guidelines together. And quite exciting, we have a patient registry, which is now gradually being rolled out across our 57 hospitals. We've also written a book on rare and complex urology. So this evening's webinar is on transition zone pull-through definition, functional consequences and management. And we're honoured and delighted to have with us Professor Jacob Langer, who is a surgeon at the Hospital for Sick Children in Toronto. And he will be presenting this webinar together with Professor Joep, Derikx, who is a paediatric surgeon at the Emma Children's Hospital in Amsterdam. It's part of our colorectal series and it's produced in collaboration with ERN ERNICA. It's also supported by EUPSA, and there are accredited continuous medical education points, so please do fill in the survey at the end of this in order to claim those. So without further ado, I'm going to hand over to Jacob and really thank our presenters for sharing their expertise with us this evening. I hope you enjoy the webinar. Thank you.
And welcome everybody. What we're planning to do today is two presentations. I'm going to talk about the general problem of obstructive symptoms after pull-through surgery in children with Hirschsprung disease, because I think it's very useful to have an organized approach to this. And one of the causes of those obstructive symptoms is a transition zone pull-through. So Dr. Derikx is going to then dig down and get much more granular about that particular problem. So obstructive symptoms following pull-through surgery can come in a variety of different ways. That some kids have chronic constipation, some children are distended, they have crampy abdominal pain, and they have inability to defecate spontaneously and require irrigations despite having had a pull-through. And in some cases, they have persistent or recurrent enterocolitis, which is another form of obstructive symptom. And the key is to have an organized approach to understanding the specific cause of these symptoms in the individual patient, because there is a variety of different things that can cause this. And if you're going to be effective in treating it, you need to understand what the etiology is. So I'll go through the 5 most common causes of obstructive symptoms, and I'll go through this fairly quickly, but I think it's important to have this organized approach. So the first potential cause of obstructive symptoms is a mechanical obstruction, and there are a variety of different types of mechanical obstruction. The diagnosis of a mechanical obstruction is usually made on the basis of a rectal exam and a contrast enema. So some children have a stricture. Some children who have had a Yancey-Suave procedure can have a retained cuff, which has rolled down and can cause obstruction. Children who have had a Duhamel procedure, sometimes if the staple line has not been taken high enough, they end up with a spur that fills up with stool over time, can't empty because it's aganglionic, and causes obstruction. And in some cases, there can be a twist during the pull-through. So the first step in working up a child for obstructive symptoms is to rule out some kind of mechanical cause for the obstruction. The second thing is that there may be abnormal pathology at the bottom end. In those cases, a lot of times the contrast enema looks just like they still have Hirschsprung disease. There are several different types of abnormal pathology. One is the transition zone pull-through, and I won't spend much time on that now because Dr. Derikx is going to go into great detail about that. But it's also sometimes the case that there is aganglionosis, and that may be because the frozen section diagnosis at the time of the pull-through was incorrect. A pathologist made an error and said that there were ganglion cells, but there weren't. And in very rare cases, there are normal ganglion cells in the specimen. The pull-through has been done properly, but the ganglion cells are lost, and nobody really knows why that is. In some cases, it's an ischemic problem, but in other cases, it just happens. The third potential cause for obstructive symptoms after a pull-through, if once you've ruled out a mechanical obstruction, done a rectal biopsy, and demonstrated normal pathology, in some cases, the normally innervated bowel histologically may still have abnormal motility. And sometimes that is just in the left colon. Sometimes it's a global problem involving the entire colon and even sometimes the small bowel. And the way to make that diagnosis is to do a nuclear medicine colon transit study like shown here. Sometimes you can do a SITS marker study, but really the most definitive way is colonic manometry, and many centers don't have colonic manometry, so the other techniques are a good screening test. But this shows the normal peristaltic wave on colonic manometry, and this shows a child who had an abnormal motility study with manometry with no peristaltic waves in the sigmoid colon. The fourth potential cause is internal sphincter achalasia, and most of you know that children with Hirschsprung disease are missing their rectoanal inhibitory reflex, the normal reaction when you distend the rectum with a balloon and you see internal sphincter relaxation. That's the rectoanal inhibitory reflex, and that's a normal reflex. In children with Hirschsprung disease, that reflex is missing. And even though most children with Hirschsprung's, they still have an absent rectoanal inhibitory reflex, but they can overcome that non-relaxing sphincter. But in some kids, they have trouble overcoming the sphincter, and it causes these obstructive symptoms. The old treatment for that was an anal sphincter myectomy to cut the sphincter, which in many cases improved the obstructive symptoms. But the problem is that we know that many children with Hirschsprung's have problems with soiling later on, and a myectomy can only worsen that potential. And we do know that the obstructive symptoms from anal achalasia tend to improve over time. So to apply a myectomy, which is a permanent solution to a problem that is a temporary problem, didn't make sense. And so many years ago, we developed the technique of Botox injection in the internal anal sphincter. And this causes relaxation, but in a transient way. It lasts for 3 to 6 months. So therefore, it can be used as a diagnostic test in a child who you're working up for obstructive symptoms. You've documented there's no mechanical obstruction. You've documented that the pathology is normal. If you give Botox and the symptoms improve, it suggests that the internal sphincter is the main cause of that problem. And when it wears off and the symptoms return again, you can retreat with Botox, and over time, as the child gets older, and usually by around 4 or 5 years of age, they've grown out of this problem and you don't need to give Botox anymore. And then it's always important to remember that stool holding behavior, the classic functional constipation that we see very, very commonly in all kinds of children, that can be the cause of obstructive symptoms in a child with Hirschsprung's disease. In fact, I think it's probably a little more common because they tend to be constipated from their non-relaxing sphincter, and that causes constipation, which may cause a painful stool. And their little 2-year-old brain says, well, that hurts, so I'm never doing that again. So they hold it in, and eventually have to pass another stool, which is painful and sets up a vicious cycle. So if you've done all of these investigations, ruled out mechanical obstruction, done a rectal biopsy, tested the motility, and given Botox without effect, then stool holding behavior is probably the cause in that patient. And the treatment for that that has been most effective is pelvic floor physical therapy. And we've been learning more and more about pelvic floor physical therapy and how useful it can be in this population of patients. So this is the algorithm that the APSA Hirschsprung's interest group came up with many years ago. And I'll just go through it very quickly. You do a rectal exam and a contrast enema. If there is a mechanical obstruction, then that needs to be dealt with either by dilation or revisional surgery. If there's no mechanical obstruction, then a rectal biopsy is done. If it shows aganglionosis or a transition zone pull-through, then usually it requires a redo pull-through, but Dr. Derikx is going to go into much greater detail about the treatment of transition zone pull-through. If there's no significant problem with the pathology, then a Botox injection is done, and I usually actually do that at the same time as the rectal biopsy because the child is already asleep. If there's clinical improvement with the Botox, it suggests that the non-relaxing sphincter is the problem, and the Botox can be repeated as necessary until the child improves on their own. If there's no improvement with Botox, then a motility workup is done, which I talked to you about, nuclear study and or colonic manometry. If that's normal, then the child needs bowel management and pelvic floor physical therapy, which we didn't really include in 2017, but I think now is very important. If it's abnormal, if the motility workup is abnormal in a generalized way, then again, they need bowel management, potentially a cecostomy. And if it's abnormal focally, then it's best to go back and do a redo pull-through, resecting the area that was abnormal. And as I said, Dr. Derikx is now going to go into more detail about the transition zone pull-through management. So just quickly, why does this happen? Why do we have a transition zone pull-through? Well, we did a study many years ago where we looked at the topography of the transition zone by looking circumferentially all the way around the bowel. And this is a summary of the results. And you can see that the transition zone is not just a straight transition zone. There's variability around the circumference. So you may have an area where you've done a biopsy, you've found ganglion cells, but for most of the rest of the circumference, there may not be normal ganglion cells, or there may be a paucity of ganglion cells with hypertrophic nerves. And that led to the suggestion that the resection should be done at some point proximal to your positive biopsy. It really resembles, this is Mark Levitt's image, but it resembles the can of paint where there may be ganglion cells here, but not for most of the rest of the circumference. So if you would biopsy here, you may think you're in normal bowel, but much of the circumference is still aganglionic or transition zone. So how can we prevent it? There are a number of different things that have been suggested, and Dr. Derikx will go into more detail about this. One is to divide the bowel above the ganglionic biopsy site, but some people say 2 centimeters, some people say 5 centimeters, some people say 10 centimeters. That remains controversial. Some people have advocated checking the size of the nerves on the frozen section, because if there are hypertrophic nerves, it suggests that you're still in the transition zone, and 40 micrometers has been the number that people have talked about. This also is very controversial. And then I think it's very important to make sure your intraoperative biopsy is a full thickness biopsy, because a seromuscular biopsy only gives you the myenteric plexus, and there are often differences between the ganglion cell status in the myenteric plexus and in the submucosal plexus. So I believe it's very important to use full thickness biopsies. And then some people have advocated sending the full donut as your frozen section, circumferential biopsies, rather than just one biopsy from the antimesenteric surface. And I think Dr. Derikx is going to talk more about that. So I'm now going to pass the presentation over to Dr. Derikx.
Great. Thank you everyone for joining us, and thank you, Jacob, for giving this very complete overview of what to do with the kids after surgery. I'd like to go a little bit more into detail, as Professor Langer already said, about what's happening with the kids if you have a kid with a transition zone pull-through. I'm one of the pediatric surgeons in Amsterdam. These are my learning objectives for the next 15 to 20 minutes. First, tell you a little bit more about the definition of a transition zone, and tell you something about the consequences when you see a kid with a transitional zone pull-through, and then tell you something about the management. Well, this is actually the definition that we, together with another pathologist who is quite famous in Hirschsprung disease, Kapoor, has put into to define the transition zone. And as you can see here, that the myenteric plexus is maybe a little bit more important than the submucosal plexus. And actually, this is of course really for up to the pathologist to have a look at all these different kind of criteria. As I said, Dr. Kapoor already did a lot of work on it. We did a little bit of this work also the last 2 to 3 years, so we're going to publish it within 2 weeks. We took 16 autopsy tissues from babies. We said that's the control group. We had 17 Hirschsprung babies, and from all these babies, we had another look at 174 sections, and did almost the same as Dr. Langer just described. And these are our data, that we don't see that the transition zone has a longer place in a certain circumferential area, which means that you don't see a clear distribution pattern. Thus, indeed, taking a single biopsy during surgery doesn't make that much sense, because you really can see ganglions right there, while on the other side it won't be. And this follows all the further the quadrants of the circumferential part of the donut. Well, this is another study that we recently published, in which we had a look at our transition zone pull-through patients, and we compared them with the non-transitional zone pull-through patients, because our workup was to start with a contrast enema in every baby with Hirschsprung disease, and the value of a contrast enema and having a good idea of where the transition zone was about 65%. Then the intraoperative judgment, so just by the eye when you start with the laparoscopy, it's around 79%. Then we always did a single point biopsy until 2 years ago, and then we came up with 90% certainty that we have enough ganglion cell, that we have enough Hirschsprung disease resected. So we ended up with 10% transition zone pull-through babies. Another thing about the nerve fiber thickness, we also had a look at it and measured it in all the babies that we operate on, and we couldn't find any clue whether this thickness says something about the transition zone pull-through, so we don't have a look at it anymore. So what we learned of it is that you really have to be aware of the transitional zone pull-through. That's around 10% is the percentage that you see everywhere where it happens in babies that undergo surgery. What we change in our center is that indeed we go higher up than what we see microscopically, and that we always send a donut to the pathologist during surgery instead of the single point biopsy. And this has in our center really good results. That's about the first thing. And the second thing would be to talk about the functional consequences of a transition zone pull-through. Last year we studied this topic, and we published a systematic review on it. And our first question was to have a look into the prevalence of a transition zone anastomosis, or pull-through as we call it. We found 34 studies reporting on this, having 2,207 patients, and all these studies together reported 25% of transition zone pull-through. And indeed, this is really high, and we think that the reason is that almost all of these 34 studies are on redo surgery. And indeed, redo surgery is often there because you have a transition zone pull-through. So if you put away these papers which are on redo surgery and only have a look at the other studies, then we come into a much more honest percentage, I think, of 9% babies having a transition zone pull-through. So I think that's the honest percentage of everything we do right now. And then what are the functional consequences? And here again, we also had to include all the patients with redo surgery, as you can see in the last part of the slide, because this was 83% of the patients. We could find quite a high number of defecation problems of around 62%, which is really high. But if you then go back to the studies, these are only 3 of them that compare the patients with and without a transition zone pull-through. So not all the patients that have to redo surgery, then the numbers become lower. Also for enterocolitis, we find a really high number as a functional consequence of this transitional pull-through of almost 40%. But if you are diving deeper and don't have a look into the redo pull-throughs, then you come in a more normal number, I think. And the soiling and the fecal incontinence numbers of all those studies together are also shown here. So I think it's quite a poor functional outcome if you have a look at all the studies that are published on transitional zone pull-through. But I think that's because of all those studies. These 34 studies are not that good quality, and that almost everyone describes their series on redo surgery, but doesn't describe their series on transitional zone pull-through. So what we really need is better definitions on transition zone. That's why I'm happy that I could tell you in the first part of my presentation what it is, I think. We need better series about long-term follow-up, and we need better reports using the core outcome set that is recently developed. Well, to tell you more about the long-term follow-up and the management of the transition zone pull-through, I'll take you through 3 studies from the last 3 years that report on that issue. So these people from India, they reported on 114 of their kids, which 11 had a transitional zone pull-through, with a follow-up of almost 5.2 years. And what you see, that almost all of these babies or these kids were, and years later, were treated with laxatives, bowel management, or bolus injections. Actually, the things that Professor Langer just described, and that only one of these kids had to undergo redo surgery. So if you treat those patients with all kind of other things and not going into redo surgery immediately, you really can treat them well in the longer term follow-up. This is also in line with a recently published paper from Colorado, but almost described the same. They had 71 patients, 6 transition zone pull-through patients with a follow-up of almost 6 years. They didn't do redo surgery when they were when the baby had a transition zone pull-through, and the longer-term functional results were quite good, with constipation rates and enterocolitis being as high and the normal ganglionic and in the transition zone pull-through patients. And our results actually say the same. So we had quite a big group of Hirschsprung disease patients undergoing surgery of 174. 10% transition zone pull-through number I already showed you. We have a follow-up of around 7.5 years. We sent the parents or the patients the questionnaires about the function, about the quality of life, and this is what we found, that in the conservative treatment group, so the babies that we didn't do a redo surgery, had almost the same numbers of interventions or percentage of interventions as the redo surgery group, as also in our control group. So these were the babies that were not having a transition zone pull-through. So we didn't see any differences whether we did a redo surgery or whether we treated them conservatively. Also, the functional outcomes are the same in terms of diet, fecal incontinence, urinary continence, and the quality of life, and all the domains that you can measure with those questionnaires are also the same in both groups. So it's not to say that you have to skip redo surgery, you really have to keep it in mind, but I think it doesn't have to be the reflex if your pathologist is telling you that you did a transition zone pull-through. For future studies, it will be really nice to dive into risk factors that can predict the poor outcome, the poor functional outcome of a baby with a transitional zone pull-through. So, ladies and gentlemen, what I wanted to tell you is, first of all, that Hirschsprung disease treatment is really a stream work, and it also includes your pathologist. But I think it's really up to us as surgeons to avoid transitional zone pull-through during surgery. That you, for example, can send a donut for frozen sections to your pathologist. And if you're confronted with a transition pull-through, then please don't immediately do redo surgery, but first try to treat the babies with conservative kind of treatment. So this is our Amsterdam Hirschsprung team, and as I said, it's really up to teamwork, as you can see here, and I want to thank all my team members, and Jacob and I are open for questions, so thank you for your attention. Yeah, shall I read the question? Do you have a very long-term follow-up to exclude symptoms in adulthood? I have a number of patients complaining symptoms requiring a redo even 5 to 10 years after first surgery. Jacob, do you have experience with a really long-term follow-up?
Yeah, for many years, most of my career, I've been pretty conservative about doing redo surgery. And I have a number of patients, I don't know exactly, but probably half a dozen patients who had a transition zone pull through, or even aganglionosis on their rectal biopsy where the family really didn't want redo surgery. And my experience has been that they've done well. And even into adulthood, I do think they probably struggle with constipation more than the average person. And they usually develop ways of dealing with that, whether it's bowel management, laxatives, or even enemas. Some people would much rather do that than have redo surgery. So I don't think there is a long-term study looking at these patients who have been managed non-operatively. That's something that needs to be done.
Yeah, and then we have a second question. Here it is. During the first procedure, how much margin do you leave from the frozen section? Yeah, what our strategy is that we don't take we only take a frozen section after we did the pull through. So we do a pull through in short segment Hirschsprung disease, and then we send the donor to the pathologist. We start a little bit doing the anastomosis, and then we get to report. So our margin after we do the laparoscopy. If we during laparoscopy really see a transition zone, so really from small to dilated, then we go about 5 centimeters higher up. That's what we do. But as Jacob said, you can also go 10 centimeters higher or whatever. But that's our approach.
Yeah, I mean, my approach has been to go 5 centimeters. I do think it's very important to do a biopsy and get a frozen section before you do that transanal dissection. This is a point I've made over the years, because occasionally the transition zone on the contrast enema, or even the transition zone that you see laparoscopically, may not be the histological transition zone. And most people would not advocate a primary pull-through if it's longer segment disease. Occasionally, if you've already done the transanal approach, you really don't have a choice. You have to do a pull-through. And if you find on your biopsies that you're now in the transverse colon, you've already done the transanal dissection, then you have to do a pull-through with the transverse colon, which, as I say, most people would not really want to do. They would want to do a stoma, wait till the child is older. So what I've done is I usually use the umbilical incision rather than laparoscopy, but I don't think it matters. You do your biopsy, and then I've not done circumferential biopsies, but that certainly is another way of approaching it. I've generally done the biopsy on the antimesenteric surface of full thickness, and then gone up 5 centimeters.
Yeah, that's what we used to do, and then we had this 10% transition zone pull through, so that's why we adjusted it. But we don't have numbers on whether that's better yet. So within 5 to 10 years, I hope we have numbers on that approach. Then here, there's another question. What would you regard as an indication for redo surgery for transition zone pull through, and when would you treat conservatively? Do you have thoughts on that, Jacob?
I think for me, it depends on how severe the obstructive symptoms are, and whether I'm dealing with aganglionosis or a transition zone pull through, like a rectal biopsy that shows ganglion cells, but maybe the nerves are a little hypertrophic. If the symptoms aren't severe and are manageable, and there are ganglion cells, but it looks like the nerves are too big, then I would be conservative with that child. Yeah. But if you've got a child who's got aganglionosis on their rectal biopsy, and the severe obstructive symptoms where they require irrigations, cannot stool spontaneously, then I would be more likely to do a transition zone, to do a redo pull-through.
Yeah, that's exactly what we do. I think there was a reflex that if your pathologist told you that you had a transition pull-through, that everyone was going to do a redo surgery. That's also what we found in our systematic review, but we'd always wait now. We have another reason for that, complementary, because we then say to our patients, well, we have another kind of surgery that a lot of people do. It's called the DML procedure, in which half of your anastomosis is aganglionotic. So we say, well, now we did maybe a kind of a DML kind of thing. So we really start waiting now and really having a look at the patients, chatting with the patients all the time, and having a look at your functional problems as Jacob described. And then first treat them, laxatives with doing the Botox injections. And then if the complaints persist, then we would only think of a redo surgery. Yeah.
And I would also add, to remember the algorithm that I showed you, and make sure that you look at the motility of the proximal bowel, because some of these kids, that's the problem, and that requires a different solution.
Mm-hmm. Yeah, thank you. Then one of the questions is, what do you want your pathologist to tell you when the donut is investigated? Number of ganglion cells, nerve fibers. What I just asked the pathologist is, do you see any ganglion cells in one of the quadrants? So the thickness of the nerve fibers in our study that I just presented, or the thickness doesn't tell you anything. So we don't ask them to have a look for the thickness of the nerve fibers. We ask them, are there ganglion cells in each quadrant or not? That's our question.
I agree with that.
Then another one, pediatric pathologists dedicated to the intestine are not so many around the world. Do you think to circulate the specimen among them for second, third opinion may be useful to decide when to do a redo? Thank you, Paula. So, hi, Paula.
See you, Paula.
This is really nice to have a name with it. Yeah, of course, for the frozen sections, that might be, our pathologists are doing everything on digital. They are doing all digitalized right now, so that's a really nice option, and maybe also for the frozen sections. But I think for the section of the resected specimen and when they do the stainings, the keratin and so on, I think it's really worthwhile doing that if the pathologist in your center is not that experienced, because I think that the pathologist is a really important member of your team.
Yeah, we have extremely good pathologists in Toronto. We're lucky. I mean, we have such a high volume. But even in our hospital, we require 2 pathologists to look at every specimen, so to make sure that they agree. And I think if you're in a place that doesn't have confident pathologists, or if they're confident and maybe not as experienced, I think especially before offering a redo pull-through to somebody, it would be worth getting a review by somebody who's more experienced.
Yeah. Then there is another one. Do you think transitional pull-through will improve in time by ingrowth of new nerve cells? We don't know. To be honest.
I mean, it's actually a very good question. It relates to the bigger question of why do children get better with time? Many of the children with obstructive symptoms, in the absence of a clear mechanical obstruction cause, many of them get better over time. And we don't really know. We don't rebiopsy those kids because they're getting better, so we don't really know what's going on in their intestine. So that may be why. It also may be that they just, as they get older, they get smarter and they learn different strategies for achieving normal defecation. But it's a very good question.
Yeah. Then another one, in symptomatic patients, don't you think the conservative management poses a risk of complications in adulthood? I mean, what if the redo becomes required at 30, 40, or 50 years of age? Yeah, I think we already discussed this a little bit. To add a bit on that, my colleague Maman Gort is really into the lifelong guidance right now. So what we do, all the Hirschsprung patients, we keep them with our team, so to say, so with the pediatric surgeons, to don't let a surgeon who only treats adults do a re-resection or do redo surgery too soon and too often and saying, oh, what else? I'll just take away some kind of bowel and we'll see. So that's why I think it's worthwhile in this transition of care where there's so much about to really keep on following up on these patients also after they become 18 years of age. But I think that's
we don't know what these patients are like at 40 or 50 years of age. My sense is that they do get better over time. So I think that this would be an unusual situation where somebody gets so bad at the age of 40 or 50 that they would need a redo. But we don't have the long-term follow-up to know the answer to that question.
Here there's another. How do you diagnose residual disease? I mean, do you rely on rectal suction biopsy or do you prefer a full thickness open biopsy? We always do, in all the older ones, we always do a full thickness open biopsy. And I think also, not that we know it that good for the people with residual disease, but for people who have a suspicion of Hirschsprung disease who are older than 6 months of age, so the people with constipation, and if you want to rule in or rule out Hirschsprung disease, then there are quite some studies that show that the suction biopsy is not good enough because you're too superficial then. So I would always advise to do an open full thickness biopsy then.
Yeah, I mean, I would say it depends on the age of the patient. If I've done a pull through or I've inherited a patient who's had a pull through, you know, in the neonatal period, and they're clearly not functioning at, let's say, 6 months, they're still requiring irrigations. In that patient, I probably would start with a suction biopsy, and if it shows aganglionosis, then we have information that it probably was just an inadequate pull through. But and the other thing that's important to remember is if you can, you should review the pathology specimen from the and look at the proximal end of it, which should be normally innervated. If it's not, that also gives you important information. Most of the time, by the time these kids present to us with these obstructive symptoms, they're over a year of age. They're often 2 or 3, and I think an open full thickness biopsy is better in that patient population.
Yeah. Then Pim Sloot is also here. Hey Pim, all the way from Rotterdam. Thank you, Jag and you, for the nice lecture. And then another one, thank you for this valuable webinar. What is your bowel management routine?
So I think it again depends on the age of the patient. The kids who are young can often just be irrigated. That's all they need, because most of the time the level of obstruction is at the sphincter or very low down. So so just irrigating those kids, and they're also small enough that you can irrigate them pretty effectively. Once kids get older, a lot of times they become anally defensive. That's very difficult to irrigate them. So you need to start using things like laxatives, so a combination of stool softeners, but not too much stool softener, and stimulant laxatives, and we usually use Senna, but sometimes bisacodyl. And in kids where they have continued severe obstructive symptoms and you can't get on top of it, occasionally we've used enemas, either antegrade or retrograde. But that I found that you know, this, and it's a bit off the topic, I guess, but I found antegrade enemas in children with Hirschsprungs who have a normal sphincter often are not very effective because they tend to hold in the enemas.
And then the last question until now, when do you advocate the pull through, at what age? What's your opinion about that?
So are we talking about a redo pull through? Are we talking about the primary
pull through? I think, yeah.
So I like to do the pull through as soon as I've made the diagnosis, even if it's in the neonate. That's my bias, because I think you know, we can do a good pull through in a small baby. If you can do a TEF repair in a 1500 grammer, then I think you should be able to do a pull through in a neonate. But there is some evidence, although not very good evidence, that the outcomes are better if you wait 4 or 5 months. So many people are now doing irrigations and kind of getting them bigger before doing the pull through. And the reason that I haven't adopted that is, number one, the evidence isn't very strong that it's better, but also I think you take a risk of that child developing enterocolitis, which can be life-threatening. And I've had a patient who did that, who almost died from enterocolitis while I was waiting. So that's why I switched back to doing them in the neonatal period.
We most times do it at the age of 2 to 3 months, but that's more a logistical reason because there's so much pressure on the theater here and on our beds. That's, to be honest, a bad reason. If I have the chance, I prefer the neonatal period. I think the surgery is most easy then. Then another one from Alessio Piniprato. In case of redo, would you go straight for a laparotomy or would you try a minimally invasive approach, laparoscopy or robotics? Yeah, we always do laparoscopy first because it's so good to see then, and that you really can loosen your colon and the splenic flexure. And I think that's, and you can really see it good. You can have a better access, I think, to the pelvis. So I really like to do it laparoscopically. With robotics and these kids, we don't have much experience here in the Netherlands. So that's what we do.
I haven't used robotic surgery, but I think laparoscopy is the best way to go. When you're doing a redo for a transition zone pull through, in some cases, the transition zone is very short and you don't really have to go up that much higher. So the point of the laparoscopy is to just do a biopsy above where you're planning to go to make sure you've got normal ganglion cells. There are some kids where, and this is unusual, but it can happen, where they have a very long transition zone. And so the laparoscopy is also helpful for that, to do serial biopsies to get as high as you need to go. I don't think a laparotomy is necessary in most cases of a redo pull through.
No, exactly. Okay. Darren, I think these were the questions until now.
I think that's everything. So I think everyone's had a good time to send any more. So I think thank you both for answering all of those. A lot of questions today. Thank you to everybody for sending those in as well. I'll send you any other further ones come through to both of you tomorrow. A quick reminder about the survey for everybody, all the attendees. Check out our website for the future sessions. Subscribe to the YouTube channel. And I think that's about it. So thank you to everybody for attending, and thank you most of all to our two presenters today. It's been really excellent presentations and very good discussion afterwards with the questions as well. So thank you both.
Thank you for involving me.
Thank you. Bye-bye.
Take care. Have a good evening. See you all soon.